All right, for chapter 12 today, we're going to go over the protection of the patient. If you've looked over the chapter a little bit, it goes into quite a number of items, including effective communication, different types of shielding, the Image Wisely campaign, a few other things. So a pretty interesting chapter overall. This picture here shows an old X-ray unit, very menacing looking compared to today's standards. This picture over here, probably an older picture, I think like 7-8 years ago. That's my third nephew. He is the cutest of the four of them, and I do not mind saying that. Protection of the patient. Imaging procedures should be explained in simple terms. So as you're becoming full-on technologists from students, being able to explain things to patients becomes a little bit easier. Holistic approach to patient care is treating the whole person rather than just the area of concern. So you're not looking at them as just a chest x-ray, but you're looking at all the questions they may have, concerns they may have, and kind of addressing those things as well. You want to make sure you let your patients ask questions and give it truthful answers within ethical limits. So you can't answer questions like, is my arm broken? But you can kind of steer them towards, when they will get their results from their doctor. Always behave as a compassionate professional. As we're getting more and more into surveys, this is especially important because your surveys directly reflect the kind of patient care that you are giving. So make sure that you take the time to make sure your patients feel good about their trip to the X-ray department and that they get all their questions answered, whether they're from specifically our department or maybe a question they forgot to ask their doctor upstairs that you may or may not be able to answer. Mobilization restraining devices in conjunction with compensating technical factors, specifically MAS. So you can adjust quite a few things. Restraining devices, if you need to, are available, generally for kids, sometimes older patients that have problems holding still. Technical factors, specifically MAS, is definitely adjustable by the technologist. There's two types of patient motion, voluntary and involuntary. So the voluntary motion you can control to a degree, but the involuntary motion is things like the heartbeat, movement of the bowels and the gases inside, which isn't so much of an effect on us because the seconds are so low and the milliseconds, so the time is very, very low on this. X-ray beam limitation devices, used basically to confine to the area of interest. You need to make sure that you are confining only to what's needed. You do not need to open the collimation just to include more parts of the body, as those are not specifically ordered. Source to skin distance should not be less than 12 inches, as we talked about for mobile radiography, 15 inches for fixed fluoroscopes. So you got to be aware of how close you can bring the tube towards your patient. Positive beam limitation we talked about prior chapter. Auto adjustment for the collimator shutters. The coincidence between the beam and light beam must correspond within 2% of the SID. So notice that 2% comes up quite a bit. So it's pretty much a standard they use across a few different other areas as well. So if you remember that 2%, that should be able to help you on the registry exam. Exposure to the patient's skin may be reduced through proper filtration of the radiographic beam. Inherent filtration amount of 5 millimeters of aluminum equivalent is required. Inherent plus added filtration equals total filtration. We went over filtration a little bit in the prior chapter as well. Protective shielding used to reduce or eliminate radiation exposure to radiosensitive body, organs, and tissues. So shielding, you are pretty much aware of is the full-size aprons. We do have half-size aprons as well as vests. There are some glasses that you can use as well. The curtain on the fluoroscope in the fluoro rooms, also another part of shielding that's used. These are some types of gonadal shielding. Most of you are familiar with the flat contact shields. You can do these on AP or PA projections that basically lie across the body, and they're entirely made of lead all the way through, so you can adjust their positioning fairly easily. They usually come in a couple different sizes. The shadow shields, may or may not have seen, these shields right here basically hang down from the collimating head. So what this little clamp will do is it'll clamp onto the tube, and this flexible hose will go down, and then this will be suspended over the patient, basically creating a shadow wherever that shield happens to be. So the lead part of it is actually this part right here. So it's good for things like I'll say some surgery or things where you can't put the shield on the patient. if you could cover it up and move it around if it was covered with a bag, just so there's no dust that comes down on the patient, and that would be ideal. Shape contact shields, these shields right over here, they're for males. They're good for fluoro but not PA projections, because of the way the fluoroscope works is that it will come in and then it'll basically bounce off the lead and go back in and hit it like a doubling dose of male gonads. Clear lead just basically attaches to the culminating head for scoliosis films. So you may have seen something like this where there's a couple magnets on there and then there's a couple pieces of lead that will actually shield the breasts, as you see here. Now, the reason they just don't open up the collimation is that they want to see down to the pelvis and they want to see a line going across the iliac crest so they can draw reference lines to determine how much scoliosis they are. But we don't want to leave the collimation all the way open because the breasts would be dosed a little bit too much. So the compromise is to put these little lead kind of stickers on that magnetic strip so that we do cover the breast tissue as best as possible. Reproductive organs exposure when they are in or within approximately 5 centimeters of properly collimating beam, unless, however, this would compromise the diagnostic study. So with this is your legal responsibility, 5 centimeters. So if it's within 2.5 inches of the primary beam towards the edges, you need to make sure that you do shield. That means for things like abdomens for the males, because the symphysis pubis is at the bottom of the testes line just below it, is that you should shield male abdomens. Female abdomens, though, fall within this little section here. It would compromise the diagnostic value of the study because it would be inside the inlet of the pelvis. Compensating filters, we talked about these in things like the thoracic spine, because the thoracic spine is a little bit thinner towards the chest and it gets a little bit wider as it gets down a little bit more inferiorly because of the presence of the stomach and just more tissue on there. So these types of compensating filters that have these kind of edges on them, they just slide right into the collimator housing, can kind of, I would say, disperse the low energy x-rays versus the high energy x-rays so that you get a little more uniform image. Repeat radiographs must be minimized to prevent the patient's skin and gonads from receiving a double dose of radiation. Now this is the catch-all that every tech will tell you is their reason for not collimating or leaving their shutters open, maybe post-cropping, which is illegal. What you want to do is you want to get the best possible image you can the first time. So you may have to take an extra couple seconds to make sure that the patient's not moving or that you're centered correctly, or if you don't have tracking, that your bucky and your tube are actually lined up. It doesn't take that much more effort, and to just leave the collimation open the whole time for every single patient is really just doing them a disservice. So make sure you try to limit your repeat radiographs as much as possible. High KVP, low MAS techniques, basically you need to find the balance there. You're going to hear lots of different things over your career. Generally though, high KVPs are a little bit better with digital applications nowadays. When we use film, and these days here, you had to get a proper level of KVP or the image would be completely grayed out. But now with digital, you have a little bit more leeway to use higher techniques with KVs and lower MAS. Repeat analysis program, Boxing 12.3 talks about it a little bit. It's maybe correctable. They really should have a program that kind of looks at what a tech's tendencies are. The department, if everybody is missing their sinus x-rays, maybe it's time to have a little in-service, kind of go over those things a little bit more. Generally, the people in charge of that will put out little diagrams or maybe some storyboards, talk about centering points, what angles to use. But basically, there should be some type of education around the department so that people don't feel like they're dumb if they just don't remember how to do head work, or maybe they just haven't done it in a long time and they're just not trained that well to do it. So any repeat analysis program should have training as a big part of it. Fluoroscopic procedures produce the greatest patient radiation dose rate in diagnostic radiology. You've already heard that many times over, so basically the amount of time involved is so much more than a regular x-ray. Portables, GI studies is generally where you're going to use fluoro most of the time. So C-arms, or you could be doing BEs or UGIs in this case and kind of taking a look around. We'll limit your time in the room if possible, but even then it's not that much radiation. Amount of radiation received, patient, let's see, can be specified a few different ways. Entrance skin exposure, skin dose, gonadal dose, bone marrow dose. Entry skin exposure is probably most widely used. They want to know about how much the skin is being entrance skin exposure is being exposed for each particular technologist. This goes into a little bit the distance involved between them and what kind of exposure you get. Not a very clear slide, but it gives you the basic information. Protection of the patient. As you know, children are a little bit more vulnerable than adults to late somatic and genetic effects of ionizing radiation because they are still developing. Talking about a lot of cell division that's going to create a child into an adult. So you want to make sure that you are limiting your techniques a little bit and also being very wary of repeat exposures. My nephew's hair does not look this bad anymore. I think mom is cutting their hair, which is a travesty. Pregnancy concerns. So with this last menstrual period, elective scheduling, 10-day rule, lead aprons, there are a few things we can do to protect the female patients that may be pregnant. You want to use a PA projection to protect the breasts of female patients, whether they're pregnant or not. Dose for AP scoliosis film versus a PA at 60 inches is about 164 versus 16 millirad. So it's almost 10 times as much a dose if you do it AP versus PA. So you want to make sure that you are doing women PA. Men, you can do them AP. We can still effectively shield them and get their thoracic and lumbar spine closer to the IR. So it gives us a little bit greater detail. For women and girls, we're not so much concerned with that because we're really looking at alignment more than anything else. If you do, however, irradiate a pregnant patient, you want to make sure that that gets documented and the patient gets taken care of right away. Usually a physicist is going to have to come in, kind of do some studies to kind of see about how much dose that they received, and if they, figure out about how much dose is received, generally it's below the safe limits that we would consider hazardous to the fetus. So it'd be better just to admit it than to try to lie about it and try to cover it up, because that's happened in the past, and we have lost students that put somebody else's name on that completion form. Adequate collimation of the radiograph beam to include only the area of clinical interest is essential. So we mentioned this earlier before. So if you're doing like a chest x-ray on a pediatric kid in the NICU, you do not need to get all the way to the abdomen. You should look at the patient's body, get used to about how much you think the chest is, and then collimating appropriately. Because we do not want to give full body dosages because you are not aware of your centering or where you think the chest field stops. It's a little give and take because you don't want to repeat it either, but most techs are going to really err a little too much on the side of opening their collimation as much as possible. Half value layers. Let's see. These are thickness of designated absorber required to decrease the intensity of the primary beam by 50% of its initial value. So it's very easy to figure out half value layers. For half value layers, all you have to do is just go down 50% each time until you get to whatever question they happen to be answering. So if we look at this sample here and we ask you how many half value layers to get less than 14% of the original value, one half value layer is going to be 50%, two half value layers are going to be 25%, and then we go down to three half value layers, it's going to get down to about 12.5. So you basically decrease by half the remaining number each time. So in this case, 3 half value layers would be the answer. Genetically significant dose, equivalent dose of reproductive organs that received by every human would be expected to cause an identical gross genetic injury to the total population as does the sum of the actual doses received by exposed individual population members. So just a genetically significant dose, just really kind of quantifying what it would be like if everybody received the same amount of radiation. So they want to make sure that you keep the dosages as low as possible. This chapter talks about quite a few subjects, so make sure you read it through. We are going to have probably a discussion board on a couple topics like the image WISELY campaign, but very important to protect your patients, as you obviously already know by now.